Okay, looks like I finally got my camera to work. Sorry, I'm a little bit late. My name is Marina Crystal, and I am so happy to be here doing my first live video. My corporation has started a company called Reducing Hospital Readmissions Initiative. I am a medical speech language pathologist, and I've been doing a lot of different posts about what I'm doing and what my mission is right now. And what I decided to do was go live and just bring you little snippets of things that are related to what I've been posting about and what I currently do with one of my biggest clients and the number of facilities that I go to as part of my private practice. So my ultimate goal is to address the number of preventable rehospitalizations that are happening right now with skilled nursing facility patients and residents. The if if you really are on top of things, and if you've been reading the latest research, it's just mind-boggling to me, the billions of dollars that our country is spending on preventable rehospitalizations. But more importantly, and something that hits me directly every day, are the patients that are going out to the hospitals that really don't need to go. And we're finding that a lot of them are getting very sick. There's some research right now that nursing home residents that go to the emergency room are 3 times more likely to end up with infections. And the average cost that it's costing a skilled nursing facility to send out their residents who have come into their building, and within those first 30 days, within that window, going back out to the hospital, is an average of $15,200 per resident. So when you multiply that times the average, latest research is anywhere between 14 to 20% of your new residents coming in, going back out. Multiply that times the number of admissions that you're getting every month. So hypothetically, if you're getting 100 residents coming in a short window of time, depends on how big your building is, depends on how many you bring in, but let's just say 100 nursing home residents that come in. If we went on the low end and we said that 14% of them go back out to the hospital, so that's 14 people times that $15,200. Just do the math and think about what you can do with that money. And then on top of it, we have to think about the illnesses that we're seeing with these people when they come back. And that is, if they come back, then we have people who are dying, who end up losing their lives because of preventable rehospitalizations. So I came here to talk to you about just a small piece of some really important pieces that you want to make sure your nursing facility has. And one of those things is a very skilled speech language pathologist. And the reason why is because the top reasons why they're going out to the hospital is aspiration pneumonia, one of the leading causes of death in nursing homes, COPD, so respiratory failure, pulmonary diseases, and congestive heart failure. Included in that top 5 is falls and GI problems. Now, if we just took just the pneumonias, the COPD, and the people with congestive heart failure, those 3 medical diagnoses are also predictors of aspiration pneumonia. So if you're someone who's had pneumonia, you're at a much higher risk of getting recurrent pneumonia. If you have COPD and CHF and you're demonstrating respiratory changes, you have to get in there as the speech pathologist in that nursing facility. It's crucial. So without getting into much more deeply all of the evidence-based research of the people that have COPD and congestive heart failure or any type of heart disease, the issues that they are having related to swallowing, or dysphagia, some people call it dysphagia, is very, very high. There's evidence-based research saying it's extremely high, even as high as over 80% of these people. So if you have a skilled speech pathologist who is going to listen to morning report or inquire from any meetings that are happening or looking at what happened the night before or on a Monday morning, really going through and making sure they haven't missed anything regarding what happened over the weekend, they have to be able to get involved with that patient right away when things change. Things like new nebulizer treatments. All of a sudden, someone needs neb treatments that never needed it before. Someone's all of a sudden wheezing. Someone's got that little cough. It doesn't have to be a major cough. Someone's just short of breath. It's time to get in immediately as the speech pathologist. That's the first thing that you must have. The second thing is access to instrumental exams. I have been doing instrumental swallowing exams for 23 years now, and I'm not going to dance around that. Every single nursing home needs to have access to FEES exams, fiber optic endoscopic evaluations of swallowing. When they are able to see what's happening, that cost of that exam is minuscule compared to the cost of one patient going out to that hospital, just one person. So to spend a couple of $100s on an exam and to be able to possibly save that person's life and prevent them from going to the hospital, prevent them from getting sick, and prevent you from spending all of that money, that exam, access to those exams must be something that you have in your building. And the third thing that I want to talk about is Section K of the MDS. We're under PDPM. We've been doing the patient-driven payment model for a long time. And under that section, your speech pathologist hopefully is filling out Section K. It's very important, number one, because they have a whole different standard upon which they evaluate residents and evaluate the swallow and look for different signs and symptoms. They are trained, hopefully, in being able to answer those questions and how those questions need to be answered. There's much more involved besides just the one-liner and taking it literally how that reads. There are many trainings, and there's also a really great Facebook group also for speech pathologists to and have their questions answered and to feel much more skilled at being able to do that section. That is where you're also getting your reimbursement. And also that is where under Section K, where dietary will put in the diet, you'll be able to look at the modified diets and relate it to hopefully the IDSI diet. So if you don't have the international dysphagia diet, I always get the entire acronym wrong, IDDSI. So it's the International Dysphagia Diet Standardization Initiative. So in my biggest client, we've been doing that for over 3 years. And it's been great because we have the level of the soft and bite-sized diet. So, as soon as I realized that we're already doing it, we're already chopping up their food, we're already making it very small. Let's incorporate this international diet for a couple of reasons. Number one, it's going to come directly from the kitchen that way. And number two, the patient is going to be safer because it's going to be arriving at a standard size that's coming from the kitchen. You're not leaving it up to a CNA to subjectively decide what size the food needs to be cut up. So the other thing, number three, is also that your patient's going to be safer. They're going to be eating more safely, and you're going to get that reimbursement. So you want to make sure that you have that diet. You want to make sure that speech is filling out Section K. You want to make sure that the diet is supported with good documentation stating why they need to be on this diet, that they've been assessed by a speech pathologist or screened, and you have good documentation to support why they need to be on the diet, along with always a care plan. The last thing that I wanted to tell you, because I don't want to make this super long, is that I am also offering a webinar on November 29th at 3 o'clock Eastern Standard Time. I'm offering a webinar. It's going to be a 1-hour webinar where I am educating anyone that needs to be there, MDS coordinators, administrators, directors of nursing and in-house speech language pathologists who are anyone's welcome, but where you're going to get that information regarding a new approach, an approach that works, research based and medically supported care path that is going to flow so that from the time a person comes into your building, when if and when they begin to change and function and there are symptoms that are evident to nurses or whomever, that it's going to flow in terms of who do I refer to, what kind of orders need to be put in, what type of assessment needs to be done so that these hospitalizations can be prevented. So I hope that you can join me there. You can also go to my website. It's www.rhri.health. And on that website, you'll be able to click on there to register for that webinar. And I think that's it. I'm here for you to help you to make those few changes. It's not difficult. It's really something that's actually a simple transition. And I love doing this. It's what I do every single day. It works and it's time. So, change is hard sometimes, but you just have to think, well, you can't always wish it was easier, just wish you were better. And that's a Darren Hardy quote, and I love him. So please reach out to me. Let me know if you have any questions. And you can also DM me here right on LinkedIn as well as on YouTube. Have a great day.